So this study was actually a piece of a larger analysis that we were doing, looking at trends and indications for cholecystectomy over the past 20 years in New York, and seeing really if there's been a change in terms of how surgeons are practicing and why people are undergoing this operation over this time frame. So we utilized a great resource. It was the New York State Planning and Research Cooperative Database, which is a statewide database that collects all hospital encounters and outpatient surgical encounters in the state. So it really was a really robust data source for us in order to analyze why people were having these procedures. So we looked at categorically all patients who had both open and laparoscopic cholecystectomies over that time frame, and then we further divided it based on surgical approach, and then further went into operative indications, mainly whether they had a diagnosis of acute cholecystitis, acalculous cholecystitis, gallstone pancreatitis, biliary dyskinesia, or biliary colic. And based on that, we found some interesting findings which prompted this subset of information, which is what we were presenting here this week. We were looking at characteristics of patients who underwent cholecystectomy for the diagnosis of biliary dyskinesia, and not just risk factors that are typical in terms of age or racial background or other comorbidities, but whether there are other socioeconomic factors that were contributors to those patients whether there were other factors that played into them undergoing surgery for removal of their gallbladder. So there were several factors we identified, one being older age, female gender. Also, there was a larger prevalence of cholecystectomy for biliary dyskinesia in patients who were of higher socioeconomic status and of patients who had commercial insurance in our data. I think a lot of people experientially might guess at some of these as being trends, but I think actually more important than what we saw was sort of what we didn't see, because we saw continued growth in the frequency of operations over this time frame. But it's a little bit hard to believe that this would only occur in this tier of patients. I think more telling is the fact that there's probably a large group of patients that are less advantaged and that are actually at risk, and this actually demonstrates potential disparity in our healthcare system, that patients who have resources that present with symptoms, that they go on to further diagnostic modalities and eventually come up with this diagnosis and may undergo surgery in order to treat it, whereas other patients with nonspecific pain without signs of infection, without signs of gallstones, may go into this category of undiagnosed abdominal pain that may not ever lead to having surgery, which might potentially be beneficial. I think the thing to take away from this study is that there are factors that put patients at risk for diseases. And then there are studies like ours which look at why we do certain procedures. Those aren't necessarily the same, and when they aren't, we need to think about whether we're actually not treating people that need treatment.